Shiva
Uh,
Krishna.
Everyone, sir doesn't need any introduction. Sir, over to you. Please help us and guide us for this.
Thank you, Dr. Kashinath, and welcome to all FIPM fellows. And you are in the final phases of the lecture series, and I extend warm greetings to you all on the occasion of Navratris. And I'm very sure Ma Saraswati will bless you all, and you will all become very successful pain physicians and do good quality service to the society and to the nation. I, Dr. Naveen Malhotra, Vice President of Indian Society for Study of Pain, feels immense pleasure in welcoming our speaker for today, Dr. Preethi Doshi. Ma'am, can I have the first slide, please? The previous slide.
Yeah,
And
sure.
Madam will be talking about a very important topic. Please do not think that it is a uh, very advanced thing, so I won't be able to do it. No, madam will make it look so simple to you. And I also look forward to listening to her once again on spinal cord stimulator and neuromodulation. Madam has been director of pain medicine at Jaslok Hospital and Research Center at Mumbai. Madam Preeti Joshi is program head for pain fellowship at the same hospital, and she is the president of Neuromodulation Society. She is faculty on board for EPIN and PGCC course on neuromodulation at London, UK. She has been organizing secretary of so many international meetings on neuromodulation, including the one in 2022 at Mumbai. She is former vice president of Indian Society for Study of Pain, former GC member of Indian Academy of Pain Medicine and Indian Society for Study of Pain, and she has been chair in 2017 for IASP and ISSP hybrid pain course at Jaslok Hospital, and she has been organizing secretary for the international symposium and workshop on advanced pain management therapies in November 2007, organizing chairperson for ISSP Con 2014 in Mumbai, scientific chairperson for Global Update of Pain in 2009 and 12, organizing vice chair on Global Update in 2015, winner of Pain Ambassador Award in 2018 and 19, 2018-19 at ICRA 2019, and she has authored many articles and chapters and textbooks at national and international platforms. And her area of interest, I can say, since I have witnessing Madam since last more than 2 decades, is neuromodulation and now regenerative medicine. So welcome, Madam Preeti Joshi, and we look forward to your talk on neuromodulation. I'll request if you've got any questions from Madam, please keep on typing in the chat box. And Dr. Kashinath Bangar, thank you, Dr. Kashinath, for agreeing to moderate today's session. Will coordinate on behalf of Indian Academy of Pain Medicine. Welcome, Dr. Preeti Joshi.
Thank you so much, Dr. Malhotra, for those kind words of introduction. And I would be happy to present today on spinal cord stimulation, mainly how and when I do it in my clinical practice. So I'm sure most of you here are aware that neuromodulation is modulating the activity of central, peripheral, or autonomic nervous system by delivering focused electrical energy or a pharmaceutical agent directly and precisely over the target by means of an implanted device. So although neuromodulation in broader term means, many other aspects also, I will be focusing mainly on the implantable therapies today. So practically neuromodulation can be used to, treat a variety of disorders, right from headaches to urinary incontinence, and has been very popularly used for over 5 decades now. And there has been tremendous progress in the field. And this is actually the future of pain medicine, according to me. And basically, it can be broadly categorized into two types: neurostimulation and intrathecal drug delivery system. The major focus today is, of course, going to be on spinal cord stimulation, which is a part of neurostimulation. So, what exactly is spinal cord stimulation? It involves altering the neural activity through targeted delivery of electrical stimulation to a number of neural targets in the epidural space. And it's a minimally invasive therapy, non-destructive, reversible, to provide ongoing analgesia, and it can be very successfully used in the algorithm of treating severe refractory neuropathic pain syndromes. So as most of you will agree that neuropathic pain is a very, very prevalent condition seen in the pain clinic practice. And the prevalence is estimated by a variety of literature globally to be in the range of 7 to 10%. But it can be variable depending on the exact entity that we are talking about. For example, in low back pain, it can be present in almost 37% patients. In diabetes, 32% patients. In India, actually, it is much higher than that. Post-herpetic neuralgia in 19% of individuals, and post-surgical pain, 10% of individuals. So neuropathic pain can be variable depending on the condition that we are looking at. And despite a number of pharmacological options and several newer molecules, almost 50% of patients fail to obtain adequate pain relief. And if we translate it into the current population of India, almost 7 million Indians have refractory chronic neuropathic pain. In 2014, the NICE guidelines recommended spinal cord stimulation as a treatment option for all chronic pain conditions of neuropathic origin, which have a level of 50 on a scale of 0 to 100, and which have persisted for more than 6 months in spite of the appropriate conservative management. According to this paper published in Pain Medicine by Bates et al., the algorithm of neuropathic pain nowadays includes neurostimulation much ahead of considering the other therapies. So it is recommended that do not consider neurostimulation and spinal cord stimulation as a rescue or a salvage therapy. It should be considered much earlier in the algorithm of chronic pain, especially with the current opioid epidemic, which is happening in the Western world. Much before you consider opioids to treat patients, neurostimulation should definitely be considered. So, which are the conditions where we can offer spinal cord stimulation? Basically, if we look at the main and very rewarding indications, it can help Sorry, yeah. Any problem?
No, madam.
I'm muting
think-
all so that they can unmute themselves. So
Yeah. Somebody's sound is. This is, madam. You are visible and
Please
audible.
go ahead, madam. Please go ahead.
Okay, so the main indications which have been found to be very rewarding in clinical practice are neuropathic pain involving upper or lower extremity following spinal surgery. And this is labeled in the recent times as post-spinal persistent spinal pain syndrome type 2. Complex regional pain syndrome has been types 1 and 2 both have been one of the other very, very rewarding indication, and pain associated due to ischemia because of the peripheral vascular disease or angina are some of the other indications where also spinal cord stimulation has shown very good outcomes.
Madam, please unmute yourself.
Yes, madam. You are unmuted. You are visible.
I think you muted everybody, so probably mine also went mute. Okay.
Please continue, madam.
Okay. Okay, so the main indications are neuropathic pain involving upper or lower extremity following spinal surgery, what we call nowadays as PSPS type 2. Complex regional pain syndrome type 1 and 2 are another very useful indication. Pain due to ischemia resulting from either peripheral vascular disease or refractory angina is also a good indication, and neuropathic pain resulting from peripheral nerve damage. There are certain other indications where one may consider spinal cord stimulation, but the results can be equivocal. So, however, when we have run out of all the options, we can consider it for patients suffering from post-amputation pain following surgery or injury. And stump pain, however, is seen to respond better as compared to phantom pain. Partial avulsion injury of brachial plexus also is a good indication for spinal cord stimulation. Eggshell pain following spinal surgery, and especially the newer high frequency stimulation has been found to be quite useful for this particular condition, although mainly the spinal cord stimulation is recommended for radicular pain. Pain involving the thoracic valve, either following surgery or post-herpetic neuralgia. And these patients can also be offered SCS or pain associated with spinal cord injury. There are certain indications which respond very poorly, and one has to be cautious not to offer SCS to these patients. So this is central pain of non-spinal cord origin or spinal cord injury with complete loss of function of the posterior columns. What is very essential is to have all these four pieces of puzzle put together to get the best outcome and success from SCS therapy. So you have to choose your patient correctly. You have to choose the right technology. You have to advocate meticulous, correct skills. And also you have to keep a vigilance on these patients after implantation. So after implantation doesn't end the story. We have to continuously monitor these patients, offer them care, and do programming as and when required. And I'll talk about this in my some other slides. So based on the literature evidence available internationally, the International Neuromodulation Society has been proposing various guidelines right from year 2014 on a regular interval, basically to provide safe outcomes from spinal cord stimulation. And we keep on getting this every 2 years updated. And somebody who's really interested in SCS should go through these guidelines on a regular basis to keep their knowledge updated and to advocate some of the advice and words of wisdom from the experts and the key opinion leaders who have vast experience and who have very high implantation rates. So we have to follow their advice and incorporate that in our clinical practice to give better outcomes to our patients. So it is very important that we prepare the patients correctly before we undertake trial of spinal cord stimulation. So a multidisciplinary team assessment is what is advocated. And it is not just a pain physician. Maybe we may have to take help of our psychologist, our psychiatrist, our colleague neurosurgeon, neurologist, to make sure that we are selecting the right patient. One has to fully explain the procedure to the patient, the stages it involves, and take an informed consent. Investigations, as for any intervention, by and large, the blood work, it is very important to do an MRI scan to exactly know the status of the spine, because we are going to implant these electrodes into the spine. So to know your entry level, to know the exact deviation from normal, it is very important to have an MRI scan performed within a year of implantation. If there are any comorbid conditions like hypertension, ischemic heart disease, diabetes, asthma, hypothyroid, they need to be optimized. And as regards to the anticoagulant and antiplatelet therapies, again, one has to advocate the same precautions which we do for any other interventional procedure. Fitness for monitored anesthesia care and general anesthesia is also desirable. So although this therapy is done under local for the IPG implantation, we may need to give a short general anesthetic to these patients. But if they are high risk, again, it can be performed under local. So we have to do a proper preoperative planning to optimize the patients before the trial. First of all, very important is select the indication correctly, optimize the general health of the patient, rule out any contraindications. In this, a major psychiatric comorbidity is very, very important to be ruled out. because otherwise those patients will never get okay, even with an SCS, if they have a very major psychiatric comorbidity. Explain the patient again, the procedure, the stages, the outcomes, and the restrictions that they may be advised to have after having an implantation done, because MRI and there are certain other things like the theft detectors or the scanners at the airport, which they will have to be careful. And what you need to explain to the patient also is a realistic outcome. So if they are expecting my pain is going to go away 100% for the entire life, it doesn't happen that way. So they need continuous monitoring, titration of the therapy, etc., which they have to be aware about. Recent MRI scan, as I mentioned, select the right technology. So we have a wide array of leads and IPGs, and one has to choose depending on various other factors. Level of entry and final position of the lead will depend on the distribution of the patient's pain. Decide and mark the site for IPG placement. So depending on the patient's body habitus, bony landmarks, clothing preferences, joint mobility, etc., one may have to vary the site of IPG implantation slightly. So most importantly, again, I would like to reiterate that appropriate patient selection and counsel them. Timely application, again, as you can see in this study published by Kumar et al., if the spinal cord stimulation is offered within the first 2 years of onset of pain, there is a good success rate of 84%, which declines almost to 1/10 of 8% if it is offered to somebody who has chronic pain going on for more than 15 years. So one has to keep this in mind and try and offer the stimulation therapy well within time to get a good outcome. Rule out any major psychiatric disorder. A successful trial is very important before proceeding with a permanent IPG implantation. After implantation, they require individualized programming as well as comprehensive management. So physical and psychological rehabilitation along with the programming are very, very essential. Coming to the stages, there are 2 stages, mainly the trial, which is performed by and large on an awake patient. Although there are, some centers in the Western world where they just do it under GA. Sometimes they just put the, they do anatomical placement of the lead and then they subsequently do programming. However, at our center, we keep the patients awake. We may give them good monitored anesthesia care and sedation to make them awake, especially when we want to record their response of intraoperative stimulation. So trial is basically like a test drive. So before you go to buy a car, you experience, how the car feels like. So in the same way, when you do a trial, the patient actually gets the feeling as to how he is going to feel when the therapy is actually given on a permanent basis. So there are different types of leads, and even in permanent, we have a cylindrical lead, which delivers the electrical stimulation across the 360 degrees, or we have surgical pedal leads, which are placed by a small laminotomy in the dorsal epidural space. So generally the trial happens for about 3 to 7 days. And if the patient gets more than 50% relief from their pain, we proceed with something called the permanent implantation of IPG. So as regards to the OT, again, one has to be very, very careful about all the sterility precautions because these are surgical procedures. You have to make a small incision and implant the battery also in the subcutaneous pocket. So one has to be very, very meticulous about the asepsis. Ideally, you need a positive pressure ventilation in the operating room. You have to keep the operating room doors closed and minimize the traffic that one has during the process of implantation. So this is how the trial is performed. Patient is positioned in prone and a paramedian oblique approach is taken for introducing the 14 gauge 2E needle. You elicit a loss of resistance and then a lead is introduced under live fluoroscopic guidance. And you can see here, this lead has contact points, as you can see. So there are various configurations. It may be a 4 contact point or an 8 contact point lead. It is placed against the dorsal columns very close to the midline. Once it is in satisfactory position, we start giving an external stimulation with a device like this, a physician programmer, and we have a combination of cathode and anode, with which we can offer a particular stimulation pattern to the patients. Now, the level of lead or the final lead placement level will depend on the pain distribution. So it can be placed anywhere from C2 to T11. So mainly for the upper extremity pain, we will place it anywhere from C2 to C6. For chest wall and heart, for angina patients, we will try and place it at T1, T2. For low back and gluteal regions, we place it at T8, T9. For legs, it will be T10, T11. And if the pain is below the knee, then generally it may be T11 or sometimes even T12. So this is a brief video. Now just tell me if you can hear the audio also. Paramedian oblique approach, where you start about 1.5 to 2 vertebral levels below the intended epidural entry. Pressure. That's the loss of resistance. Once you get into the epidural space, we will try to introduce the lead. Remember to be close to the midline, and we have a curved stylet with which we can steer the lead into the desired direction. I prefer to generally make a epidural entry on the same side. So as you can see now here, my lead is being introduced. Cafelard. That's the T12 rib. Now I'll keep going Cafelard.
Then we will advance it more.
As you can see, the tip is now being curved towards to stay close to the midline. And once tip is placed in the desired location, we will start with doing what is called as intraoperative stimulation. So we connect the proximal end of the lead.
I explain to you, we are going to start that stimulation now. So you will feel a little tingling now in the pain area. Okay? You let us know when it starts, and you have to tell us also whether it matches with your pain distribution or not. Are you listening?
Yeah, I'm just starting it.
It's a very young patient with
Lower back.
CRPS
Okay, go up.
of the right lower extremity.
Is it increasing the stimulation?
So as you can see, the patient is
Sir,
awake.
going down your leg now on the left side.
Yeah.
Where is it now?
Okay, so once the satisfactory placement has been achieved, we keep the trial, as I mentioned, up to 7 days. And then if the patient is satisfied and if the physician is also satisfied, we proceed with implantation of an IPG. We have, again, a wide array of IPG, rechargeable as well as non-rechargeable. So depending on the patient profile and comfort, we decide which battery to implant. This is a short clip about how we put the IPG.
Matching with the contact points there.
Now, this is one of my more recent videos. So this is a newer This is called as a WENS, which is wireless external neurostimulator. There are 8 contact points because nowadays we use octaves.
Start the button. Yes. The green. Already connected.
So once we do this, we connect it to a tablet.
Please tell us.
It is, actually, it both are there.
What we have to ascertain is that the paresthesia should be concordant to their pain distribution.
Right from the button down to toes.
You got it there, bottom.
So high.
Yeah, okay.
Okay. And right is more than the left.
Yes,
Correct?
yes.
But you're getting all the way up to the toes.
It's the right.
On the right side. 5, 6, 7 negative and 4 positive. Is getting majorly response on the right side. All the way up to the toes. 10, 11, 12, 13, negative, 14 positive.
We can see that is the tablet nowadays which we use.
And 5 minutes. Just let us know once as soon as you start feeling something. Okay, sir? Anything right now on 5? Which one? Back on the left side. Okay, what about the thigh? Calf? Okay, go up slightly. 6. 6 now. Is that spreading now? Sorry? Where all? Which areas? The left leg entirely. Yes? And the back also. Okay, but leg is entirely covered. Okay, great. Okay.
This is a special anchor which helps to anchor the lead to the dorsal fascia. This comes along with the lead kit, which is made by Medtronic. And this is the intelligent battery. This is a rechargeable battery, as you can see here. So the proximal end of the lead goes into the battery, and then we have a screw wrench to secure the proximal end of the lead into the battery.
It's ready to check.
This is a tablet with which we first check the impedance, and then we can give the different groups to the patient during the trial. So we check the impedance. Once the connections are secured, then it is implanted in a subcutaneous pocket. Okay, so it's also very important to follow the correct meticulous technique. So antibiotic prophylaxis is must because it has shown to be reducing the incidence of wound infections by 50%. We have to give weight-based dose of the IV antibiotics at least an hour before the surgical incision is made, either cephalosporins or clindamycin, and within 2 hours before the surgical incision with vancomycin. So there may be some patients who may be resistant to this, and we may need to give vancomycin. So generally we give one single dose, and although in my clinical practice, if the patients are diabetic, I do give them IV antibiotics for at least 48 hours and then continue it up with oral antibiotics also. So somebody who's beta-lactam allergic can be given IV clindamycin or vancomycin. And if we know if the patient is MRSA positive, then we may have to use vancomycin. You also nowadays get a special antimicrobial envelope called Tyrex, which has shown to reduce the infection rate by 70 to 100%. So this is very useful, and it gets absorbed over a period of few weeks. Appropriate preparation and technique is absolutely essential. The overall risk of surgical skin infection was significantly lower in patients who were prepared with chlorhexidine alcohol and then followed with povidone iodine group. You have to consider 3 minutes of thorough cleaning with chlorhexidine followed by 30-second cleaning with povidone iodine. And if you incorporate this operative steps such as minimizing the devitalized tissue, eradicating all the dead space, doing wound irrigation for removal of all the debris, foreign material, blood clots, etc., and installation of antibiotics. This can further reduce the chances of surgical skin infections. And we have to apply occlusive dressings after the end of the surgery again to keep the wound sterile. Aftercare of patients is equally important. So patients have been asked to follow up on regular intervals. One has to be vigilant initial periods for any signs of infection, seroma, hematoma, hygroma, etc. And redness, discharge, fever, nuchal rigidity, or any neurodeficit, the patient is advised to immediately report to the emergency medicine department. Watch for any signs of wound dehiscence, headache, which may actually indicate a post-dural puncture headache or meningitis. So again, one has to be very, very cautious to pick this up in a timely manner. Instruct the patients about how to use the programmer, how to charge the battery if it's a rechargeable battery. Instruct them to avoid strong magnets, especially the scanners and theft detectors at the malls and airports. So these patients are actually given an ID card, which they just flash at the airport, and they are exempted from passing through the scanners at the airport. Avoid monopolar diathermy for any other subsequent surgery not related to this. And if they have to, for any other surgery, require a neuraxial analgesia or anesthesia, ideally one should avoid and give general anesthesia. But if cannot be avoided, then one has to use, all thorough asepsis and ideally image guidance also. And once implanted, they come for regular follow-ups. And we have to keep a watch for any, change in the coverage or paresthesia or loss of coverage, any discomfort that they may get at the site of IPG or any aberrant stimulation. And all this may need to be paid attention, and they may require reprogramming. Nowadays, we use this kind of tablet to do the reprogramming. This was the older Envision programmer we used to use for the earlier devices, but nowadays we are using this for intrathecal pump as well as for the spinal cord stimulation. So like any other intervention, again in surgery, there is a likelihood of complications also, which one needs to be aware about. The commonest being hardware and technology related complications, which are very common because we are using the hardware for implantation here. It can be sometimes to the tune of almost 1/3 of the patient. So please be aware about this and take precautions and try your best. However, many a times it may not be in your hands and you may have to deal with these complications and correct them. So 13% of patients are known to have migration of the lead, especially the cylindrical percutaneous leads. Breakage of the lead in 9% of individuals. There may be a malfunction of the battery in 3% of patients, and a battery failure can also occur in 1.6% of patients. Biological complications in form of infection, CSF leak, hematoma, seroma, wound dehiscence, and visceral injury may occur in 3 to 5% of patients. And sometimes there may be miscellaneous complications such as aberrant stimulation. You don't want stimulation in a particular area, but it is just keeps going to that area. Pain over the IPG site, or very rarely an allergic reaction is also likely. So how to reduce the risk of migration, especially in the cervical region? If you're putting a percutaneous cylindrical lead, there is a good chance of that coming out, because cervical spine is a very mobile area. So when the patient subsequently does movements of rotation, flexion, extension, there is a likelihood that the lead may migrate caudally and the effect may be lost. With an octet, sometimes with reprogramming, you can achieve the capturing the paresthesia again. However, sometimes you may need to reposition the lead. So it all depends on the operator experience, a very meticulous technique. Anchoring has to be done properly, and we have something called a strain relief loop also. And the newer technology has given us better configuration of the leads and the special anchors, which help us to reduce the rate of migration. At the site of IPG, again, there may be excursion of the lead and extension cable. This is much higher if the IPG is implanted in the gluteal region versus the anterior abdominal wall. One has to, however, place the battery within 2.5 centimeters from the skin to allow a telemetry and programming. So this is important to keep in mind. As a precautionary advice, the patients are asked not to do any vigorous movements and activities for 3 months at least, and a cervical collar is recommended for patients who undergo cervical spinal cord stimulation. Bleeding is another complication, and epidural hematoma risk may be 0.3%. However, the risk of paralysis is quite low. With a meticulous technique, I think it is impossible to get this problem. However, how do you detect hematoma? So patient may sometimes complain of just mild discomfort, or if it's a big hematoma, they may complain of sudden exacerbation of the back pain. And it can also lead, if it is at the site of the IPG, it can lead to wound dehiscence, and potentially it can also lead to infection. So bleeding can occur while placing the needle, lead, IPG. It can also occur during removal. So one has to be very, very careful. And if at all a hematoma happens, it has to be evacuated within 8 hours. Another risk is surgical site infection. Again, pre-existing diseases like diabetes, obesity predispose these individuals to higher risk of infection. Of course, the surgical asepsis, operating room environment, antibiotics, asepsis, sterile dressing, etc. have to be looked into very, very carefully. Reduce the operative time. That is one other thing which has been described in studies, that if the stimulation time and the operative time is reduced, the chances of infection are minimized. The main contributors to infection are found to be duration and complexity of the lead implantation procedure, use of a percutaneous lead or extension during a trial period, because extension, half of it will remain outside while we are doing the trial. So there is a higher risk of contamination rather than just directly proceeding with an IPG implant. Duration of trial is ideally recommended to be definitely less than 10 days, because if it is beyond that, then the risk of infection is increased. Okay, now what is the evidence? So we have a number of papers published in the literature to prove that spinal cord stimulation is really a good, effective option. There is a level 1 evidence as per this systematic literature review published in Pain Medicine in 2020 by Timothy Dear. He is considered to be the main stalwart of spinal cord stimulation. And this is a paper published by a group of experts here, which says the SCS is level 1 evidence or strong evidence for axial back pain along with lumbar radiculopathy pain or neuralgia as per 5 high-quality randomized control trial and 1 high-quality randomized control trial for complex regional pain syndrome. So these are some of the indications where definitely there are excellent outcomes. And in my personal experience, CRPS is one of the very, very good indication and very rewarding indication. Okay, another systematic review. Again, cost is a major problem, especially in our country. However, it is said that, there are studies which have kind of shown that SCS is a cost-effective therapy when considering long-term treatment for patients with neuropathic pain. So because they may have to be otherwise on a number of medications and may need to undergo several other interventions also, hospitalization. So all of that will altogether the aggregate cost will be much higher than the initial cost of SCS implantation. And it is actually also published that if within 3 years or 4 years, generally the entire cost can be recovered, the initial upfront cost which the implantation involves. So spinal cord stimulation with conservative medical management is cost effective as compared to conservative medical management in managing FBSS, CRPS, peripheral arterial disease, and refractory angina pectoris. And this is as per this Pain Medicine article again. The spinal cord stimulation has undergone evolution over the past, especially over the past 2 decades, when we have several newer devices available. And the initial outcome, which was about 50%, has now steadily improved up to about 85%. There has been a number of technological advances in the design of the lead as well as the battery. There has been refinement of the targets. Also, there are certain novel waveforms like burst and high frequency, which are comparatively giving better outcomes. So this is the whole gamut of newer therapies that we have. We have something called dorsal root ganglion stimulator, high frequency stimulator, Senza. We have closed loop stimulation in form of adaptive stim. Precision spectra the spectra wave writer is a Boston Scientific battery which can offer different waveforms at different times. So that actually takes care of the plasticity and tolerance which may happen with these devices. I would now like to just present some of the cases which I have treated in my practice. So this was a 71-year-old female patient, mother of an orthopedic surgeon who had degenerative scoliosis. 2015, she was operated once, then she developed infection. So second time, and then she developed a loosening of a hardware. So she was operated 3 times. And then she developed severe pain affecting the medial aspect of dorsum of her left foot with a pain of 9 on 10. Which was impacting obviously her mobility, her quality of life, everything. She was actually on opioid and she had to be taken to EMS for fentanyl infusion because she used to have severe aggravation of pain episodically. So this was a patient whom I had actually prepared that we might have to place a surgical lead, but fortunately I was able to put a percutaneous octet in the very first go, and this patient had complete control of her pain during the trial. So on the third day, we implanted the IPG, and this happened in November 2022. And till today, she is absolutely pain relieved and she's using the system very comfortably. She's been off all analgesic drugs and doing very well. So this is her video. I don't know if you all can hear the version.
Mrs. Narmada Ben Patel. She's 71-year-old and she had 3 previous spine surgeries. She had
I may
already
just
a child
actually
of 1
FF
year
because
old and
just for the sake of time.
original દુખાવો હતો એ કેવો લાગે છે
અત્યારે બિલકુલ નથી.
સો 100% છે તમને ફેરફાર 100% relief છે
So
right?
she has 100% pain relief. That's what she says. Okay. Another 41-year-old lady with road traffic accident and spinal cord injury, which happened in 2015. She was seen by me in 2021. Actually, she was an international patient. So initially, she had presented with severe pelvic pain and urinary retention, and she used to require a CIC almost 4 to 5 times in a day because she couldn't pass the urine spontaneously. So I explained her and offered her a trial of sacral nerve stimulator, which you can see here, and she had very good response. She completely went off catheterization. So I offered her an interstim implantation in 2022. She also had radicular pain down her lower limbs because of the spinal cord injury. So she actually, I had counseled her for spinal cord stimulation also. So she came the next year in 2023 because she continued to have severe unremitting radicular pain in spite of all the analgesic medications and simpler interventions. So I then placed 2 octaves in her thoracic spine from T9 to T12. And on 6th day, I implanted her with an Intellis rechargeable IPG. So patient got very good relief from the pain as well as she went completely off catheter. So she's right now using both these stimulators very effectively and very useful to improve the quality of life. So this is her version while she was in the hospital.
3/10, which means it's about 70% relief.
Okay. And it's there constant, the sensation, you feel it nicely
Yes.
and you are able to do all the activities which you would want to do later on.
Yes.
Your sleep has improved,
My sleep has improved.
your appetite is good,
My appetite is okay.
And you think your walking ability, your working ability will also improve with this?
I'm really hopeful that
Yes.
my life will.
So this was
never
actually
change.
immediately after the
Excellent.
trial,
So we will
and
be proceeding with the
she just came
implantation
for
of
a follow-up
implanted
also into
implantable
April
pulse generator
25, and
tomorrow.
she's still doing
So the
very
whole
well and
system will
using
be
both the
internalized and you
stimulators very effectively. This was another gentleman, 65-year-old, and he also had a PSPS type 2.
Hello, I'm Subhash Morir and my age is 67 years. On 17th August 2015, I was operated on the spinal cord for lytic listhesis L4, L5, along with severe root canal stenosis. The operation was successful. However, early 2019 onwards, severe pain was experienced in the right hip near anal area. Heavy medicine dosage was started, but the pain persisted. I was unable to lead a normal life. 2022, the problem had escalated to an unbearable level. Therefore, I agreed for spinal cord stimulator trial. After a successful trial, the spinal cord stimulator was implanted by Dr. Preethi Doshi. Within a couple of hours of the implant, the pain had reduced by about 30% and by another 40% when I was discharged 3 days later. Simultaneously, the reduction of medicines was undertaken in a gradual manner. Nearly 75 drugs have been withdrawn. Consequently, I am attentive, relaxed, with better reflexes, and can drive the car. The insertion of the spinal cord stimulator has been a game changer for me, and I am fully satisfied. Okay, please see that I am walking and I have no discomfort at all.
So he went off all the drugs that he used to take, and he had significant improvement in his quality of life. Okay, this was another 69-year-old female patient with severe pain of the right upper extremity, all features of CRPS type 2. She had a schwannoma of her upper trunk of right brachial plexus, which was excised 2 years ago by a neurosurgeon. She had initial pain relief for about 6 months, but then recurrence of pain, severe burning pain involving right side C456 distribution with a severe intensity of pain, swelling, redness. So she had all full-blown features of CRPS. She had a repeat MRI scan to rule out the recurrence of schwannoma. She had stellate ganglion block twice, which offered her short-lived relief. However, the pain used to come back. And then I explained her the trial of spinal cord stimulation and implanted her with a unilateral octave on the affected side, the right side, which was actually her dominant hand. And she was a very active lady. She had to perform a lot of activities. So every time she would do something, the pain would aggravate. She had a good trial and very good response. So then we implanted her with Genesis XP. Now, this was quite a few years ago. And then this battery, we replaced it with a rechargeable battery. And this lady has used this device very, very successfully for about 12 years with complete remission of all her symptoms and a normal restoration of her, activities of daily living. She can do everything. All the features of CRPS2 have been completely controlled. So again, very, very rewarding in her case. Now, to create awareness, actually, in December 2023, I published these two review articles in the Indian Journal of Pain. I was the lead author for this. Basically, these are best practice recommendations for implantable neuromodulation therapy, spinal cord stimulation. And the second part is intrathecal drug delivery system, peripheral nerve stimulator, and sacral neuromodulation. So those who are interested can go through these review articles and get some more information about the therapy. In 2021, I published a paper in Neuromodulation Journal, which is a journal of International Neuromodulation Society, about the practice trends of neuromodulation therapies for pain and spasticity in India. So what we analyzed was we did an online survey of the practicing clinicians who are doing the pain implantations, and we found that many of them are very reluctant to use these neuromodulation therapies in their practice, and we tried to analyze what were the main reasons for it. So cost of the therapy was a major deterrent. This was kind of the feedback from 85% of clinicians. Lack of awareness by 70% of clinicians, lack of training by 60% of individuals, and access to the therapy in our country was felt to be poor by 53% of the clinicians. Acceptance by the patient, again, this is a major problem which I also experience many a times in my practice. The patients say that, no, I don't want an implant for my pain. So as against the experience in the Western world, where the patients were so willing and open to accept the therapies, implantable therapies. In India, we face a lot of resistance. The industry support, again, is not the best here in India, and 50% of the clinicians felt that they had lack of access to the hardware also. And the modest success of the therapies, because almost 27% of patients can develop tolerance over a period of time. But in my personal opinion, I think if we do good programming and if we understand the therapy and give proper attention, this tolerance phenomenon can be overcome quite easily. So I think to end my talk, again, SCS is a non-pharmacological therapy, very, very useful in the times of opioid epidemic for ongoing relief of severe refractory neuropathic pain, including post-trauma pain in select patients. Consider this earlier in the treatment continuum rather than an end-stage salvage therapy. You need to pick the right indication and offer comprehensive patient care. And these are the mainstays for the success. Technological advances, newer targets, newer waveforms offer a lot of promise to improve the efficacy of this modality. And the application can be extended to a larger group of patients by awareness at various levels, improved training of our practitioners, access to newer technology, and getting the reimbursement approvals, because cost is a major, major problem. However, this can be facilitated by collective efforts and focused academic activities of clinicians, insurers, industry, individuals, and national societies like Indian Society for Study of Pain and the Neuromodulation Society. The application on a wider scale can be possible by Make in India concept. As our Prime Minister always says, we all have to work hard for this. And of course, there are some developments, but if we can make it in India, it can definitely become more cost effective. In 2018, we established the Neuromodulation Society of India, which is an Indian chapter of International Neuromodulation Society. I happen to be currently the president of this society. It's a society formed by, multiple disciplines, such as pain physicians, neurosurgeons, neurologists, psychiatrists, urologists, and rehab specialists. And basically, the goal is to promote academic and scientific activities in the field of neuromodulation, all of them to come on a common platform to interact for the betterment of the therapy and offering it on a wider scale to our needy patients. So we facilitate futuristic goals also. So this is the website of the society. Those who are interested to become members, please contact me personally or on tnsindia2017@gmail.com. We do very regular national conferences. We concluded one earlier this month in Kolkata, TNS 2025, which was again a very, very successful event attended by about 350 clinicians from different disciplines. And I invite, before I end, to all of you to join us from 7th to 9th May 2027 in Mumbai for the next National Congress of TNS, and the registrations will be opening very soon by this weekend. So to conclude, I think all of you will agree with me that pain has several components: physical, spiritual, social, emotional. So treating chronic pain, just with one modality is like fixing a car. It requires fixing a car with 4 flat tires. If you inflate just one tire, the car is not going to work. You need to work on all the aspects to get the complete and total control of pain. And with that, I would like to thank you all for your attention. Thank you. So I think I will stop sharing now.
Thank you, madam, for such a nice lucid talk on such a important topic, spinal cord stimulation,
Thank you.
and you made it look very easy and very impressive work over the last many years.
Thank you.
Dr. Kashinath, I think there are certain questions in the chat box. If you can take up
Yes,
one
sir.
by one.
Yes, sir. Madam, good evening.
Yeah,
As
good evening.
always, a wonderful talk.
Thank you.
One more time. Yes. Ma'am, there are a few questions. I'll read it for you. Uh, can you please explain the topographical mapping of cervical, thoracic, lumbar, and sacral regions at dorsal horn of spinal cord? This
Okay,
is from
so
Mahi.
Mahi, okay. Are you, oh, Mahi is still there. Okay. So
I,
basically,
Hmm.
the mechanism, there are many proposed mechanisms, although the exact mechanism of how spinal cord stimulation works is not clear as of today. A lot of research is going on, and basically it was devised on the based on the gate principle. However, that alone cannot explain. There are several other explanations as to how spinal cord stimulation works. In the recent times, there is a lot of emphasis also given to the microglia and the glial cells, which till now were just thought of as supporting cells, but there is a very important role played by these cells also in the in the analgesic mechanism of spinal cord stimulation. Now, so topography wise, I know it's a little difficult to understand, but there is supposed to be something called antidromic nociception. So, if I want coverage of, say, sole or the foot, I would put, although we know that it is L5S1 and those dermatomes, we will place the electrode at the T11 or T12 because the neurons, the entry is at that level, and by stimulating that, you can create or you can provide paresthesia of the sole or the foot. So similarly, it also applies to all the different segmental levels. So for example, if I want to cover up C4, C5, I would place the lead at C2. Okay, so that is what is actually a little difficult to understand, but I think as you do more cases, you will understand. And what is very important is here again, we go by a broad general knowledge, but what is most important is the intraoperative stimulation, which can be very different in different individuals and different patients. So we cannot apply the same formula for each and every patient. You have to go by individual assessment of the patient during the trial, which is basically in the theater. And once you get a satisfactory response in that particular distribution, you will anchor the lead at that location.
Okay. Two more questions are there, madam. In chronic pelvic pain, whether unilateral placement of lead is sufficient or bilateral should be there?
Chronic pelvic pain, again, it's a very difficult problem, but it again depends on the patient presentation. So if patient has both side pain, then you better put two leads. However, there are some clinicians who put the lead in the midline, and that also can cover both sides. So you can, depending on your preference plus your patient's budget, you can decide whether you want to put one. But I would ideally put two leads because I have more freedom to have different combinations. Basically, you are going to configure the stimulation by combining the cathode and anode stimulation. So if I have two octaves, of course, I have more scope for combinations and giving a better coverage. And very often it is seen that after implantation also there is a continued pathological process and plasticity, neuroplasticity, which may change the stimulation pattern. And the patient comes back that, okay, my pain has come back. Then we need to again choose a different combination, change the pulse width, change the frequency, and give the patient again restore their pain control. So it all depends on patient to patient. But yes, you can put one lead if you if you put it in midline. Many a times it covers both sides.
Madam, again the question is needle entry point for the target lead placement at T10.
At T,
T10. Needle entry point for the target leads placement at T10.
T10. Okay, so we can go from L23 or L12.
Okay.
Yeah.
Madam, should we follow PAC guidelines or NAC guidelines?
Okay, so good question. Now, NAC guidelines are neuromodulation appropriateness consensus committee guidelines. These are mainly for the spinal cord stimulation, whereas PACC or PAC guidelines are polyanalytic consensus committee guidelines for intrathecal drug delivery systems. So NAC is for stimulators and PAC is for the intrathecal drug delivery systems. Okay, so they are both proposed by International Neuromodulation Society, and they are both for a different purpose. But they come out regularly with these guidelines based on a group of experts, key opinion leaders, and that are very useful very often in our clinical practice. So one has to be in constant touch with these guidelines.
Yes. Madam, that patient of lower limb CRPS, how was its recovery and how long the implant remains there?
1 minute, which one? So
Madam,
that was actually a PSPS type 2, the one who was walking, right?
probably related to that, that this is a question left
So,
lower limb.
CRPS,
Yes.
I presented one female patient with an upper extremity right hand CRPS. And that
Lower
was
limbs. It was the question is about lower limb extremity.
so for lower limb, this was what I presented were both patients with PSPS type 2.
Okay.
Okay, and they are still using it. So I have implanted in 2022, both these patients actually. And they are still using it very well. It is good enough to take control of their pain.
Yeah. Any insurance coverage? I think this is anyway.
Yes,
For the body.
this is very, very relevant and very important. And yes, we do have insurance coverage now for many of my patients are getting insurance coverage. Of course, but the cost of the therapy is pretty high. The implants totally, if you're putting 2 leads and a rechargeable battery. So rechargeable battery is the only one which is available currently in the Indian market. So previously they had non-rechargeable batteries which were a little cheaper, but now it's only rechargeable batteries and the cost comes to about 14 lakhs total, 14 to 15 lakhs.
No.
So that becomes quite a prohibitive cost. So not many people have that kind of insurance, but some of my patients have managed to claim from 2 different insurance companies and they've got full coverage. Definitely, the hospitalization cost will be covered by the insurance. I have had that experience for quite a few of my patients. Implant costs, sometimes they can create a problem, but the newer insurance companies, the private insurance companies, I think are quite open to that. And many of my patients are getting for intrathecal pumps also the reimbursement.
So the 14-15 lakh is total cost or a cost of implant?
That is the only the cost of the
Cost.
implant, the
Okay.
hardware. Yes,
Yeah.
and with the dollar cost going up, these costs are revised because these devices are only made in the US. As of now, we don't have any indigenous devices.
Yes. And there is another question from Mr. Mulla. I think you had answered, but anyway, for any pain, is entry from the lumbar area only?
No. So if we are putting at cervical level, then you would enter. So ideally, you should enter about 2.5 to 3 vertebral levels below the epidural entry, and then you can guide it up to the desired level. So if I'm putting a cervical SCS, I would go from a thoracic level. But again, it's a lot of operator preference. So some clinicians, even abroad, they go always from lumbar approach and reach the cervical. I personally feel that that can increase the chances of lead migration. So don't put a very long length of lead inside because the longer the length, the more are the chances of migration. So
Madam, any canal below which we should not be putting canal diameter?
Yes, exactly. So that's why I said one should do a fresh MRI within a year before the implantation because you want to see the dimensions. So if it is a very tight stenosis, again, it's going to be a big challenge also to steer the lead because there is hardly any room there. But it is not recommended because there can be more pressure and sometimes it can lead to, complications. So I think there is no hard and fast rule about it. But if it is moderate to very severe stenosis, one has to be careful. Okay, so I think there is one other question. Any time limit to in terms of duration for SCS application? So if you mean that the time of implantation, it should be ideally within 2 years from onset of pain. Because the more chronic the pain becomes, the maladaptive neuroplasticity goes to an extent where then again, doing anything may not be very useful. So one has to keep that in mind and try and do it as early as possible. Of course, it's not always possible because it's not in your hands. When it all depends on when the patient comes to you, and some patients are very motivated. They want to try out anything to get rid of their pain. So, but as I showed you in the graph, if we delay it more, the chances of success of the outcome declines. And the rechargeable battery has a span of about 10 years. Okay, so if you mean that how long you can keep it, 10 years and then you can replace it if the system. So as I showed you, one of my patients is using it for past 12 years and very effectively. So she had a change of battery. Lead you don't need to change, you need to change just the IPG. Any other questions?
I think it has been an elaborate session on neuromodulation. And still, if you feel that there are any queries or questions, you can contact Madam on email and she will happily reply to that. Thank you, Madam, for sharing your valuable time. And it was pleasure attending this session. Thank you very much.
Thank you so much. Okay, good night. Bye-bye.